supervisors, dear colleagues and guests, good afternoon and welcome to the last session of today's project meeting. I've got two projects, and if I want to put one title for both my projects, that would be the management of hemodynamic instability in gastrointestinal bleeding. I'm Mahmoud Obeidat from Jordan. I've studied general medicine at Obeidat University here in Hungary, and I started my PhD afterwards. They say having good supervision is a key of success. My supervisor, who I had the chance to meet 3 years ago at Obeidat University, he was my gastroenterology teacher, and he had a great motive for me to drag me out here. And indeed, I'm pretty sure that I am in the right place. My SMS, Brigitte Teutsch, who I'm learning every single step of different methodologies, I would publicly like to thank her and other SMSs for all the work they're putting to come up with high quality presentations in a very short time. Our statistician Daniel Versch, and as I said before, I have two projects regarding gastrointestinal bleeding, and both of them regarding hemodynamic instability. So my vision would be to improve the outcome and care for hemodynamic instability in gastrointestinal bleeders, and maybe at the end come up with a guideline-based treatment, because there are gaps in the guideline. And my mission for that would be, other than fulfilling my projects, of course, to mathematically prove the high incidence of hemodynamic instability in gastrointestinal bleeding, and to understand variability in the different treatment methods. Here's a quick overview of my two projects. My first project is looking at the incidence of hemodynamic instability in gastrointestinal bleeding, and my other project is looking at the management of hemodynamically unstable patients who come up with non-variceal upper GI bleeding. My first project is going to be a systematic review and meta-analysis looking at the incidence of hemodynamic instability in patients with gastrointestinal bleeding. Well, I want to emphasize a few points here. The incidence of GI bleeding is around 100 per 100,000 cases annually, with an estimated mortality rate up to 15%. And many studies show that hemodynamic instability is significantly associated with mortality. And in some cases, the incidence of hemodynamic instability can be very high. Like in one study, they showed that 44 of non-variceal upper GI bleeders come up with hemodynamic instability, while 66% of variceal bleeders come up with hemodynamic instability, which is very high numbers. So the aim is to know the exact number, as Peter mentioned at the beginning of the meeting, that we believe in numbers. So we are looking for some numbers here. So the question is, what is the incidence of hemodynamic instability in gastrointestinal bleeding? And we use the Coco framework for that. So the condition is hemodynamic instability, context is the gastrointestinal bleeding, and the population is going to be adult patients more than 18 years old. And the clinical implication is going to be to increase awareness for all medical doctors that this population is at high risk of mortality, so we want to give them more attention, and because in some cases, as I mentioned, the mortality rate can be very high as well. And in one article, while I was doing the full text selection, they mentioned if the patient comes with massive GI bleeding and develop hemodynamic instability, the mortality rate increases up to 40%, which is a very high number for GI bleeders. We have done the systematic search on 14th of October, and we've got around 11,000 hits. And my search key consists of two main parts. The first part is basically the source of the bleeding, upper GI bleeding, lower GI bleeding, and the second part is about hemodynamic instability or shock. And this is a very nice flowchart of my progress until now. We've got 11,000 hits after the duplicate removal. We've got 9,000, and after the title and abstract selection, we've got 600, and now we are working on the full text selection. Well, I think we need just a couple of days and we will be done with that as well. My second project is going to be an international survey. about the management of hemodynamically unstable patients who has non-variceal upper GI bleeding. So we narrowed our population to only those who come with non-variceal bleeds, because variceal bleeding is a different story. My background about this topic is almost the same as the first topic, but what I would like to add here, that there's gaps and uncertainties in the most recent update in the EGSC guideline regarding the management of non-variceal bleeders who come up with hemodynamic instability. They clearly stated that we have some uncertainties and gaps how to treat these patients. They just mentioned that we give them crystalloid fluids, but they mentioned that there are uncertainties. What is the optimum rate of the fluid? What kind of fluid we should give these patients? So for that, the aim is to understand the assessment, the care, the management of those patients by doing an international survey. And we plan to do an online questionnaire for doctors to fill, and we want to understand the variability of the different treatment methods. And that's going to be my hypothesis, that there is significant variability or heterogeneity between the different treatment methods. And we believe that's based on years of clinical experience of the doctors and, of course, the individual patient factors. And for that, to understand that, we are building a questionnaire and divided into 3 main sections. The first section is going to be about the demographics and clinical practice for the doctors who are going to participate in the questionnaire. We're going to ask how many years they have been in practice, what kind of hospitals they are working in. Is it like community-based hospital or university hospital or private clinic? And what is the focus of their specialty? Are they just general gastroenterologists? Are they working in the ICU? Are they advanced endoscopists? So we have a couple of questions for each section. Section number 2 is going to be about definitions and terminology. We want to understand what is the exact definition of hemodynamic instability, because after reading some articles, there is no consensus even in the definition of hemodynamic instability. They define it as, if I want to simply define it, that's basically the systolic blood pressure less than 100 and heart rate more than 100, and in some articles they include syncope. But in other articles as well, they play with the numbers, so sometimes it's less than 90, less than 120, less than 115, so we want to see what is the exact definition of that. And the third section, which is the most important here, it's going to be about the stepwise assessment and management of non-variceal upper GI bleeders who develop hemodynamic instability. And this exact section is going to be subdivided into 3 main subgroups again: the pre-endoscopic assessment, endoscopic intervention, and post-endoscopic care. And we have a couple of questions for each group, but I don't have enough time to present the questions today. Hopefully next time, when we are now in the phase of discussing the answers of some questions. This is a flowchart of the establishing the survey, and we already come up with the survey idea, the decision about the survey, and now we're discussing the questionnaire, because we want to make the questionnaire as simple as possible for the doctors to fill, because if it's complicated, I think many doctors are gonna skip it. And this is an overview of my 2 projects. Hopefully we're gonna submit the 2 projects by next year in April and July. And before I close my presentation, I want to close it with a quote by Isaac Newton, who said that what we know is a drop and what we don't know is an ocean. And I think that's like general for all majors, but specifically for medical field, that if we don't know something, we have to admit it. And I thank you for your attention, and if there are any questions, I will be more than happy to answer.
Fantastic, congratulations for the presentation. Actually, I would like to ask an advice from you regarding your second project. What is your advice to the others how to approach international centers that they will complete your questionnaire? What is that? So the question would be, if we would talk one by one, then what is the strategy? But let's have an advice for the others how to proceed in this methodology.
So regarding the question, thank you for the question, by the way. As I mentioned at the end of my presentation, that we want to make the questionnaire as simple as possible to fill. So there are some questionnaires with freestyle answers. And I think most of the doctors don't have time to start writing answers for all the questions. So we are planning to give very high quality answers for each question. So it's going to be like multiple choice or a single choice and questions. And the doctor is just going to pick the most proper answer that they think this is the most scientifically believed answer in his opinion. This is one point, to make it as simple as possible. There are any other methods, for example, providing money for the doctors to fill the questionnaire, but I think we've already this is not amusing. This is not the one I'm using. I'm just like giving some ideas, because in one survey I was reading that they provided like $100 for the doctor to participate. But one more point that we were discussing, I think, to give co-authorship for the doctors who participate in the questionnaire.
Thank you very much. I agree.
So you were mentioning that because there is no clear suggestion in the guidelines, you want to have an international survey. So I was wondering if you are planning to collect data, what available approaches they have, because they're using that approach because that's available for them, or because that's financially supported. So that might be.
What do you mean by approach? To treat the patients?
Yeah. So maybe they have just one opportunity to treat the patient, but maybe they have three, but only one is financially supported in that disease. So that's why they try to use that approach only. Maybe they use that because they think that's the best approach.
Well, as I mentioned at the beginning of my presentation, that there is variability for the different treatment methods. And in the hypothesis that there is significant heterogeneity. So, and in the background, there is gap in the guidelines. So there is no specific protocol that it should follow. So, and in my hypothesis, I mentioned it depends on the individual patient factor as well. So not all the patients are going to be treated the same way.
What I wanted to highlight is that in different countries, there are different financial supports for different treatments. In Hungary, that might be different than in Romania or in Belarus or even in America. So that's why I wanted to highlight this, that you should focus on what they have, why is that available.
We'll take it into consideration then. Yeah.